Good afternoon, my dear colleagues. It's an honor to share my knowledge and today's presentation with all of you that joined the webinar. And at the end of the webinar, there will be a section on question and answer. So whatever you have or you think about something you want to ask, please do it at the end, and we'll try to answer to all the questions according to the time we have. The today webinar is, as you can see from the title, is about the use of a new non-resorbable cell occlusive membrane to improve bone preservation and augmentation. Why there is a need for this, why we're talking about this today, because we know that GBR procedures are now performed on a daily basis in our offices, as well as socket preservation technique are applied almost every day in on our patients in our clinics. And the webinar today will start, of course, it will be divided in 3 parts. The first part is the background, so where we started from when we started to perform the GBR, to do GBR procedures back in the 90s. What are the needs now for clinicians compared to what we were doing in 90 years back in the 90s, or what materials we were using back then, what are the materials we should have or we would need now, what are the evolutions, where we are now with the GBR techniques and with the materials. And if possible, if we have something that they can join and can add the needs and the evolution, so to have a very high performing material to be used in on an everyday basis. Let's go to the background. And what's the background? Basically, when we were performing a GBR technique, we always use a membrane and a grafting material. Today, we're not going to discuss about any grafting material because it's beyond the scope of this presentation. I'm focusing my presentation mainly on the membrane. So back then, back in the 90s, at the early 2000, we were using membrane, a grafting material. Of course, back then, a membrane was a non-resorbable membrane. The most common membranes we were using were the EPTFE, the Gore-Tex membrane. And this is a typical case of those years, a very thin ridge. Of course, here you can dispute, you can discuss, so you can use a graft, a block, autologous, homologous, whatever. I was using grafting articulate graft with a Gore-Tex membrane, typical GBR technique. And so this is the case with the membrane in place and with the grafting material in place. Now, the most important thing back then was to have a primary closure to avoid any opening of the flap, so to avoid the exposure of the membrane. Those were membranes that they will get contaminated from bacteria if exposed to the oral cavity. So we knew back then that we needed a primary closure and the wound to stay closed for the completed time of the healing, which was anywhere in between 6 to 10, 12 months, according to whatever material you or we were using at that time. But quite often, this is what we were seeing after certain time, after a month, or not even a month, even earlier, with these membranes. We were seeing exposures, and we knew from the literature, from the experience of other clinicians, that what we will need here is definitely taking out this membrane. Sorry. taking out this membrane to avoid contamination, to avoid superinfection, which will need an abscess, antibiotics, failure. But anyway, we had to go in and remove that membrane. But what do we know from the literature? From the literature back then, we knew that we will see an exposure anywhere in between 7% and 44%. I know 44% is a very high percentage. I'm not saying that we were seeing an exposure almost in 50% of our cases, but we were definitely seeing some exposure. And according to whatever level of surgeons we were, we will see more or less exposure of the membrane. And as I said, when a membrane was exposed, we needed to remove it. To remove it anywhere in between 4 to 6 weeks after the exposure to avoid superinfection and to avoid abscesses and failure of the grafting material. Now, if this is the background where we're coming from that we need to move forward. We need something different because this is, it was working, but it was very dangerous, very stressful sometimes for clinicians who use those kind of membranes, because you will see exposure, a failure of your technique, plus you need to tell your patient that they need further surgery, another surgery not planned. So it was a little bit stressful and not really friendly, the use of those membranes back there. So what our needs are compared to the background, to the start. The first thing is a non-bacterial contamination if the membrane was exposed. So we will need something that if exposed, it won't get contaminated. And of course, the first answer was the use of a non-resorbable membrane. Now, the non-resorbable membranes are very high performing. They perform very well. They're very satisfying, I would say. Now we're celebrating 10 years of a JSON membrane, which is a very, I would say, an excellent membrane. I've been using the membrane for a long time, and I have to say that its strength, it's the strength, meaning that has a very high tensile strength and is a very high performing membrane, is very easy to handle. Let me remove the arrow, I'm sorry. And an excellent surface adaptation. You see, and you know this from the company, from the manufacturer anyway. And as I said, we started using some resorbable membrane and test them in GBR, and knowing that with an exposure, we won't get any contamination. But we were getting even higher performances, even with those resorbable membrane. This is a typical case of an horizontal GBR performed simultaneously at the insertion of the implants. And you wait for the maturation of the tissue. I waited in this case around 9 months. And this is what you see when you take a CBCT to see the maturation of the tissue. You see all this tissue around the implant, protecting the implant. And this is what you see here on the second implant. But when I went in and I reopened to uncover the implants, this is what I found. See here, all these material, grafting material is covering the implants. I don't see the implants, and I showed you the x-ray. So this is the case with the implants in, and this is what I found when I reopened. So I can say here that there is a very high performance of the membrane, because the membrane allowed me to obtain this result, plus the grafting material, obviously, but this is mainly the high performance of the membrane. So in this case, I had to go in and look for the implants, and I found the implants uncovered with the second stage, saying that even a resorbable membrane can perform in a very high fashion and can be very performing, I would say. Another case where I went in after 8 months from the GBR technique, And this is what I found. See, I still see the resorbable membrane underneath the flap, meaning that even if per definition this is a resorbable membrane, you can have some surprise. You can see the membrane still there, still in place, and not resorbed. But sometimes it gets exposed. What happens if this membrane get exposed? Per definition, a resorbable membrane exposed resorbs faster. So we know if this membrane is exposed, it won't get contaminated, but it will get resorbed much faster. So it won't perform the way we've seen in the previous slides, but we will lose the barrier effect if exposed. But sometimes we leave this membrane exposed, so it's kind of an intentional exposure, especially when we do socket preservation. I do perform socket preservation when I expect some contraction of the socket, when I'm sure the socket will contract. I know the contraction and the resorption of the socket is not predictable, but sometimes from the x-rays you can tell that this socket, one socket, will change the shape and will resorb, especially when you don't have 2 millimeters of buccal plate or you have a missing plate in the socket itself. In a case like this, you see the premolar here that needs to be extracted. You see how thin the buccal plate is. Some of it is missing as well. So you need to rebuild all these in order to achieve the same height as the palatal side. So in this case, I will use a technique called ice cream cone technique. And the ice cream cone technique is performed by using a resorbable membrane cut in an ice cream cone shape with the ice cream scoop on it that will be used as a trapdoor. Basically what you do, once that you extract the tooth here, then you cut a membrane in an ice cream cone fashion with the ice cream scoops on it, and you stick it into the socket, leaning on the aspect on the plate that you're missing, in this case against the buccal plate inside the socket. Then you use a grafting material, in this case a xenograft material. Then you use the ice cream scoop as a trapdoor. In this case I use the fleece membrane and close it with a figure 8 stitch. Why I'm using a fleece membrane? To delay a little bit the resorption of the resorbable membrane, because per definition, if left exposed, this membrane will resorb much faster. So I left this membrane exposed, this membrane with a fleece on, in order to achieve a better result. Then, of course, when you perform a socket preservation, you have to wait, because you're delaying the healing, plus you're putting some grafting material that needs to mature. So you go in, you take the first x-ray. In this case, I took the first x-ray quite soon, 5 months. So I wasn't really happy with the result here. I still see something maturing here, so it's not completely compact. So I waited longer, and then I said to the patient, come back in a couple of months, we'll take another x-ray and we'll do the implant. The patient disappeared for about other 6 months, and she came back 11 months later. And this is what I have now. 11 months later, I rebuilt the buccal plate here. I maintained the volume, so I'm ready to place an implant here. And so I did. So this is pretty straightforward. What I want to say, though, is that if you use this kind of technique and this kind of membrane, definitely you get a resorption sooner than when you're performing a GBR. Another case, an abscess on a first molar, probing quite deep. Of course, when you're dealing with this kind of situation, you need a CBCT in order to study the shape of the socket and how the place of the sockets are, if you have the walls that are intact or not, what you have to rebuild, what you have to preserve. So anytime I'm doing a case that I have doubts on, I take a CBCT, especially in the anterior region. In this case, I took a CBCT here. This is what I found, a huge chronic infection from a post-encore and root canal therapy, which wasn't well done. And this is what I've seen, what I see on the X-ray. So big infection. Now I need to take out this tooth. I take this tooth out. What happens? See how thin the buccal plate is. Here, if I get, if I wait without doing anything, I might lose all this buccal plate. This is less than 2 millimeters, so it might not be stable after extraction. I might get some contraction during the healing. So that's why here I decide to do some socket preservation. And again, I did here extraction of the tooth, placing the grafting material inside the socket, and using, again, another fleece, a JSON fleece in this case, figure 8, and then I waited. Of course, I know this will get resorbed quite faster. Do I need much reconstruction here? Not much. I need to maintain the buccal aspect mainly. And as I said, since we're delaying the healing, we need to wait longer before placing an implant. So this is the downsides of any socket preservation technique. If you perform a socket preservation, you have to wait longer before placing the implant. And so I did. This is 12 months. And see how much bone I maintain here. I maintained all the volume. I still have the buccal plate. I maintained the volume underneath sinus floor. So I'm quite happy. I can place the implant now with no problem. So I go in, place the implant, nice 4.5 millimeters by 10 implant. So I'm quite happy with the result, and I can go after the implant placement to the final restoration. And this is the final restoration. So quite happy. But as I said, in these cases, you've seen the use of resorbable membranes used in a socket preservation technique. And most of the times I get nice results, but you might get burned by using a resorbable membrane in these cases. So the next question is this the best choice? Is always, the resorbable membrane the best choice to adapt in socket preservation? This is a lateral incisor that needs an extraction. I'm missing the buccal plate. I can tell because I have here an infection. Almost have a fistula. It's not a real fistula. It's just a small abscess, but I can tell from this abscess formation that I don't have a buccal plate. So what I did, I performed an ice cream cone technique. Again, cut the membrane in ice cream cone shape with the ice cream scoops on it, and then place this part inside the socket against the buccal plate or against the plate you're missing. In this case, it's the buccal plate, as I said. So placing the membrane is a resorbable membrane. Here you see it here, the placement of the membrane against the buccal plate, leaving this trap door open at the moment. Then you insert the grafting material, and then you use these ice cream scoops as a trap door to close it and to maintain the grafting material inside the socket. And this is it. Obviously, as I said, I always use a JSON fleece to cover the resorbable membrane to delay a little bit the resorption of the membrane left exposed. Then I waited, and I can tell already from the clinical view that I'm missing something here. So I went from a convexity of the root eminence to a concavity where definitely there is no appearance of the root eminence. But then of course, I take a 3D, a CBCT X-ray to evaluate the volume and the bone, the quality of the bone I have. Here I see a lot of width. I definitely can place an implant safely. But then looking at the frontal view, I see this dome-shaped sort of void here, and this is a little bit scary. Even if I performed a socket preservation, I didn't save much. I still have the two peaks, so I'm lucky enough to have the two peaks, mesial and distal, to rebuild this bone here, but I haven't maintained what I thought. So this is a problem. That means that I probably didn't choose the right material, the right membrane, I would say, because in this case, the membrane resorbed faster. So in a cases like this, this will tell me that I definitely need something different. When I went in, I found what I've seen on the X-ray, a mesial peak here and a distal peak here. So I placed the implant, and of course, the void I was seeing on the X-ray is there. The threads are exposed. So I need to perform a GBR, a classical GBR now, which is a more cost for the patient. Without telling the patient, of course, it's a more cost for you more than the patient, because when I make a mistake and I have to do a procedure that wasn't planned, I won't charge the patient. So it's coming out of my pocket, the regenerative procedure here. But I did a regenerative procedure. I had no alternatives. Taking the impression, so at the second stage I can place the temporary on, doing the typical GBR procedure with the membrane, grafting material, primary closure, and of course you wait. Here I waited 8 months. After 8 months, this is what I got. So I rebuilt the contour, getting definitely a convexity and regain the root eminence appearance, like the root here of the adjacent teeth. And again, now this is the X-ray. Of course, I need to take the X-ray to make sure that the bone was there. I still have some grafting material protecting my implant. I know that in this case I will stable, because this material won't get resorbed in the long term, because per definition is a non-resorbing or a slow resorption rate material. And again, placing the temporary, waiting now for the tissue to mature. And this is the final case. See the contour? I'm pretty happy. I went from a concavity to a convexity. Of course, I had to perform a GBR. So it's a procedure not planned, as I said. Why? Because I used the wrong material, because I probably choose a membrane that resorbed too fast and didn't maintain the barrier effect. So I lost some grafting material. I've lost the effect of the socket preservation. And this is 1 year after. Quite happy, quite stable. See the contour. Even you see more maturation of the soft tissues. You have the papilla, mesial and distal. I can be quite happy here. No complaints. But now, let's go back to the needs. So we've seen that if we need something that if it gets exposed, doesn't get contaminated. But now we have something that if it gets exposed, doesn't get contaminated, but it resorbs too fast, right? So the real need now, especially for socket preservation, if the membrane that if it gets exposed, doesn't get contaminated and it doesn't resorb. So we need a non-resorbable membrane that will have its occlusive effect even if exposed, left in an open healing. And that's why I said we'll put evolution. So those are the needs, what the evolution can be at this point. Of course, the evolution is the topic of this presentation, is the permamem. The new membrane, non-resorbable, usable in socket preservation, even in GBR, as we'll see along the presentation, but it's mainly designed for socket preservation, can be used in periodontics for GTR, but it's a high density PTFE membrane, but it's all ultra thin. It's very thin. It's less than 1/10 of a millimeter, meaning that if you placing 10 membranes, one on top of the other, you don't reach 1 millimeter. This is a lot, and it's impervious to bacteria. See here, ultra thin, 0.8, 0.08, I'm sorry, impervious to bacteria. There is no need for primary soft tissue closure. Of course, this is indication dependent. It's very rounded edges for minimal tissue trauma and easy to recover because it's a blue color, so you can really see it quite easily when you use it. This membrane, as I said, is a new membrane and has a very high performance chemically. I won't go over the result of the CME appearance, but has a very good chemical response. Oh, I'm sorry. As I said, it can be used in implant dentistry, in perio, in oral, and in craniomaxillofacial surgery. So it can be used almost in any indication. The first indication is the socket and ridge preservation, open healing. Can be used in horizontal and vertical ridge augmentation, but my recommendation is to start using it with a socket preservation. Of course, you can use it in fenestration, intraosseous defects, and furcation defects, as I said, in GTR, in periodontics. Remember, it's a non-resorbable, so if you use it submerged, you need to go in and remove it. So this is very important to remember, especially if you're using for fenestration defects and dehiscence. If you place it underneath the flap and you have a primary closure, you have to go in and remove it. You fix it or not. Why is engineered for open healing? As I said, this is impervious to bacteria. Why is impervious to bacteria? Because it has a very dense structure, has a reduced bacterial attachment, and is an efficient barrier against bacterial and cellular penetration. And these are the magnifications you can see here. This is very, very dense structure, I would say. What are the selling points of permamem? One of them is definitely the thin structure. Compared to the competitive products, you know, it's less thicker. I mean, 0.08 compared to the Cytoplast, which is probably the most common non-resorbable membrane used now, which is 0.2 millimeters. Plus, as a is very flexible, and that's a tear strength. When you start using it, you will see that you can flex it, you can pull it, but it won't tear so easily. And of course, as a reduced plaque accumulation, observation of clinical users, of course, you see it, you know, they haven't, I don't think there is any test they've done in any lab at botiss to see how much a bacterial accumulation your plaque accumulation you get on the membrane. But as a clinician, you see the difference when you use it. Why using a PTFE membrane in an open healing? This is a technique that was presented for the first time back in 2005 by Dr. Funakoshi, very well-known and excellent surgeon from Fukuoka, Japan. He basically started using the PTFE in an open healing fashion for both socket preservation and ridge preservation. Basically, he was placing the grafting material, placing the membrane above the grafting material, not trying to reach any primary closure, and then wait. He was wait 2 weeks, 3 weeks, 4 weeks. After anywhere in between 4 to 6 weeks, with a small plier, he will remove the membrane because he wasn't fixed it with any pins, and this is what he was getting: some soft tissue healing underneath the membrane, and then he will wait for the grafting material to mature. The same thing he was doing with ridge preservation here, not attempting any closure, removing the barrier after 4 to 6 weeks, and wait for the maturation of the soft tissue. So coming from this knowledge, He has published the book. He has been using the membranes for over 14 years. Of course, he wasn't using the permamem because the permamem wasn't there 14 years ago. This is anyway a PTFE membrane, high density PTFE membrane. So I started to using in the same fashion the permamem. This is a non-restorable first molar. Here you see the bone here. You lost some attachment here. You lost some bone on the distal aspect. You lost some bone in between the roots. So this tooth has a mobility, so it needs to come out. Of course, if you don't do any socket preservation, you probably end up with a major resorption that will need some GBR or probably some sinus lift teeter. So taking out the tooth here, at this point, I'm using the permamem for the extraction. I'm not using a resorbable membrane anymore. Seeking the membrane under the soft tissue here, then using the grafting material and then closing the trapdoor here. And this is it, grafting material using of the membrane as a trapdoor, closing it and suture. This is the membrane in place. You can see all underneath the soft tissue. And then taking a stitch, figure eight stitch and suture in order to hold the membrane. Then you wait 1 week, 2 weeks, or you remove the suture. And after 4 weeks, what you see is that the soft tissue will kick the membrane kind of out, so you can remove it with a plier very easily. You will see cases on this definitely. This is the healing after 8 months, and this is the amount of bone I could preserve. I have 7.5 millimeters, so I could place easily a 6 millimeters, or I can do a minor sinus lift and place a 10 millimeter implant. This is the implant inside, inserted, and this is the healing of the soft tissue. Now we're ready to go to the final restoration for this case. So I was able to maintain hard tissues because of the membrane and the grafting material, the socket preservation performed with the right material. Now I don't run with a membrane like this. I don't run the risk. I don't run the risk of a resorption, which is too fast, and I might lose some grafting material. Another case, first molar, broken first molar, not resorbable, of course. Cases like this, as I said, I always take a CBCT to evaluate the socket and the walls of my socket. And this is it. Here, you see the buccal plate is very low. Lingual plates start losing some here, some void here. So I definitely, if I take out this tooth, the healing most likely will be like this. So I'm losing all this height here. And the nerve is right here. So if I start placing the implant from here, I can definitely have a shorter implant placed in this case. So I decide to perform socket preservation. Extraction of the roots here. Always separate when you're doing extraction before placing an implant or before placing a grafting material. Membrane underneath the soft tissue, grafting material, figure eight suture here, holding the membrane in place. Now you wait, as always. You have to wait, and you leave Mother Nature to run its course. This is the post-op X-ray. And this is 1 week later. You start seeing the membrane coming a little bit out. You wait a little bit longer until the patient comes back 4 to 6 weeks. And if you can hold the membrane 4 to 6 weeks in place, this is much better. This is the 6 weeks follow-up, taking out the membrane at this point, and this is the healing you get. This is the soft tissue underneath the membrane at 6 weeks after extraction. So quite nice. Now of course, you have to wait for the grafting material to mature in 8 to 12 months. Another first molar, broken first molar, mesiodistal. This is the lateral view. And this is the X-ray. Again, here I'm losing completely the interseptal bone, so I can place an implant immediately. I see I've lost some bone here. See here, whatever I see here, I see it here into the furcations. There is into the furcation. There is no bone. Got some chronic infection. But see at the buccal plate. I'm down here with the buccal plate, with the palatal, with the lingual plate. I'm up here. So if I don't do anything, I will definitely lose most of this buccal plate for the resorption in the healing time. Extraction, of course, as I said, separate the tooth. This is the socket. See, there is no septum. I knew it already that there was no septum there because I've seen it on the CBCT. And this is the placement of the membrane, the grafting material, and the figure 8. It's always the same. Membrane, grafting material, figure 8, and then weight. This is 2 weeks. The membrane still in place. We start losing the stitch a little bit. This is a resorbable suture anyway, and this is a vicryl. 8 months. See here the healing. Of course, before going in, I need to take an X-ray, a CBCT. And this is what I got. 8 months later, I have 13.4 millimeters above the canal. This is where the buccal plate was at the extraction time, and this is where the lingual plate was at the extraction time. So basically, not only I'm maintaining, but I definitely gained all this volume here just with the socket preservation. Of course, I have to wait longer. If we want to find some downsides of the socket preservation, there are many, but there are some plus, definitely. This is a case where I see a lot of plus more than downsides. Downsides can be that you're slowing down the healing process, that you're interfering with the healing process, you're placing a grafting material in the healing socket. If I would play to be a scientist, I could say that this probably is not 100% bone, but what I care the most as a clinician, that this is stable and it will maintain my implant in the long term. And this is the reopening with the implant placement here. Then you leave the implant healing, heal for the time you need, 2 months, 4 months, whatever, and then you go to a final. This is the X-ray after implant placement. And this is the healing of the implant, and we're ready to send him to the to send the patient to the prosthodontist. Another case, a premolar. First premolar with the periodontal involvement, with the high mobility, and of course, as I said, always the same. Taking a CBCT, you see the defect here. You have a mesial and distal peak, okay, but you don't have buccal plate. See how thin the buccal plate is, almost missing here, and here you lost here. I'm sorry, you don't see the buccal plate here. You lost all these. You have all this granulation tissue here. So now you know that if you're taking out this tooth and you wait, for sure you're losing all this plate here because it's very thin, not very perfused. So you will get a triangular shape. We know that the extraction of a single tooth most of the time causes a triangular shape in the ridges, like from this article, for example, in 2016. It's basically the alveolar process following single tooth extraction. What they've seen in this article, Linde, Araujo, and Oisawa, that the removal of a single tooth caused marked hard tissue diminution, but especially in the ridge that acquire a triangular shape. So a case like the one we've seen before, like this one, let me go back one slide. Here, you've seen it already, the shape you're getting at the end of the healing, according to the literature. So you know you have to do something now, or you have to do it later. So it's better probably to do it at the time of the extraction. And so I did, taking out the tooth, cleaning all the granulation tissue, soft GBR, socket preservation with some grafting material, lateral xenograft in this case. Always I use xenograft for these cases. At the beginning, I wasn't sure which was the best way to secure the membrane, so I was trying different things, and I have to say this is much worse than inserting the membranes under the soft tissue and then put a single suture, a figure 8 suture. So I was suturing the membrane to the soft tissue, but I don't think this is a real good idea. I don't use this technique anymore, because you lose the membrane much faster, because it gets kicked out much faster. This is a 2 weeks follow-up, 2 months follow-up, and of course, as I said, you always have to wait longer and longer. But look at the X-ray at 8 months. This is before the extraction, and this is after. I definitely don't have a triangular shape there. This is something, amount of bone, I can put a very large implant, very long implant, with no problems. So this is only because I choose the right materials in terms of membrane and in terms of grafting material. And see here, you regain completely the volume here. So now I can go in and place an implant easily. This is the healing clinical opening. Now, as I said, as a clinician, do I care if this is 100% bone? Let's see here. Do I care if this is 100% bone? No, I really don't. I really care that this is stable. This could be stable. And again, if I go back one more slide, here, you see from here to here. So this is 100% bone? Probably not. This is something that will maintain the implant? Definitely, yes. We know it from the literature that socket preservation, won't, in the long term will work. So this is the bone volume I got after just a socket preservation with the right materials. Placing the implant here, easy, no brain surgery. And this is the final restoration. So I could place an implant without doing any major GBR, without doing any surgical procedure, any additive, any extra surgical procedure after the healing. So just performed in the right way with the right materials, the socket preservation. So I got a nice healing, nice englobated restoration. I am quite happy in this case. Another case of a fractured upper molar, not restorable. Here you see the fracture. This is the clinical appearance, the occlusal appearance. Extraction, see the fractures here, and this is the socket. This is the socket here, the fractured tooth, extraction, no problem. And again, placing the grafting material inside the socket, placing the membrane underneath the soft tissue with a thin periosseal elevator. You elevate a little bit of soft tissue and you place the membrane underneath the soft tissue, here, and then you place a single figure 8 suture. Always the same, always the same. 2 weeks later, start seeing the stitch that they becomes loose. 4 weeks, removing the membrane with a plier, the permanent membrane, and this is the soft tissue you see underneath. Would be better if the patient can use a toothbrush and brush his teeth or her teeth, but in this case, you see a nice healing of the soft tissue. Then you have to wait, as always, for a GBR, for a socket preservation. You wait from 8 to 12 months, and this is 8 months later. This is the bone I'm maintaining here. This is the volume I'm maintaining. I can use easily an implant there with no problems without doing any further procedure. And this is the healing of the soft tissue. Thank God the patient started using the toothbrush now. Now I can go in and place an implant. And so I didn't even reopen a major flap. I just did an operculum there and placed the implant. Very nicely. This is the lateral view after placing the implant and the healing abutment. nice implant in place, 10 millimeters, 4.5 of diameter, so I'm quite happy, no problem. I can leave the implant to heal now and place the final restoration here, no problem. So just by doing socket preservation with the right material, with the right membranes and the grafting material, you can reach some results. And this is the lateral view of the final restoration. Now, as I said at the beginning, I use this membrane even for GBRs. Now, why you want to use a GBR, I mean a non-resorbable membrane in GBR is like going back, but you use this membrane that you know that if you get exposed, it won't get resorbed because it's not resorbable, plus it won't get contaminated, it won't get infected, you won't need to remove it. At the beginning, I just used, and when I was thinking to remove it in patients at the wheel, I was expecting some opening of the at the healing time. One case I choose, I will show you. It's when I was sure because the patient was paranoid with brushing, with cleaning, and was a heavy smoker. So I decided I'm not gonna get a primary closure for the longest time. So let's try and let's use this membrane. Of course, you have to try to see in which clinical situation works better. So I started with cases like this. Now I'm using the membrane without even removing it after 6 to 8 weeks with the plier. I just leave it in and see what happens. Now I'm seeing the first cases I've done like this. I'm not presenting those cases because I don't have any clinical evidence. I can, come on a webinar and say, oh, this works even if you don't remove it. I'm saying now that I remove it. So for the time being, I say I remove it. When we meet the next time, I might say you can leave it on, you can leave it in even if for the entire healing if it gets exposed. I don't know yet. So as I said, this is a very good friend of mine. Even if he was paranoid with brushing, he was going to bed with candies, gummy candies in his mouth just to fall asleep. So he was getting all these teeth decayed from the candies. When he came to the office and said, oh, Alfonso, really the candies make that? Of course they make that. So I said, stop eating the candies and let's do something for your mouth. Here, you see here this completely destroyed first molar. Second molar is completely decayed, as I will show you on the X-ray. And as I did, of course, I went and I took a 3D X-ray, CBCT. You see here, this unrestorable second premolar, completely busted first premolar. So the decision here was to rebuild the bone here and do 2 implants with a cantilever on the first molar, which we know from the literature that they work with no problem. Here you can see that we're missing on the first molar, on the first premolar, completely the buccal plate. Even on the second premolar, we're missing the buccal plate. So I know that there, when I take out this tooth and take out this tooth, I will have a shape like this even before the healing. So when I go in, I'm sure I'm not seeing the buccal plate here and a buccal plate there. So I'm trying to rebuild all these volumes. So I go in, take out the 2 teeth here, then opening a flap. Of course, I'm opening a flap that I will try to close and release and to obtain a primary closure because I'm using a new tool, a new membrane, so I want to use it in a regular fashion, even if I'm expecting some exposure. As I said, when I take out the 2 teeth, this is the buccal plate I found, but I knew it already from the X-ray, from the CBCT. No buccal plate here, no buccal plate there. So I'm performing a typical classical GBR. And how do I perform the GBR? I use some membrane. In this case, I decide to use a non-resorbable membrane. I use the pins at the time. I'm still using the pins because I'm not sure I can perform surgery as Dr. Funakoshi does. He's an excellent surgeon. I have to say, I know him personally. He's very good with his hands. Some autogenous bone mixed with some xenograft. and then close it. We do this all the time. Close it with the permamem. You have, of course, different sizes of the permamem. You have a bigger sizes for GBR, smaller sizes for socket preservation. Use a pin there. This is the palatal pin here. Closing, fine, easy, boom, boom. Obtaining a primary closure by releasing the periosteum here. Doing some address, some interrupted, usual. I'm pretty happy. This is a primary closure, but I know this guy is going to go with the toothbrush, he's going to go with the toothpick, he's going to go with anything he can, plus he smokes a lot. So here I'm not expecting a long closure or whatever, the closure for the longest time. And this is only after 2 weeks. See here, huge opening. Stitches are, we're missing almost all the stitches. And then 6 weeks. He comes in saying, oh, I have something hanging in my mouth, and this is what I see. 6 weeks. He kicked out the pin either. So removing this membrane, just tearing it, leaving the vestibular pin, no problem. And this is what I see. I know it from Dr. Funakoshi. You always see this soft tissue underneath that membrane that will protect the grafting material then. This is 3 months. Of course, I have to wait for this tissue to mature, but I'm quite happy. This soft tissue is healing well here. Look at this. Then, of course, as I said, I always wait long enough to have maturation of hard and soft tissue. In this case, I waited 9 months. But look at the X-ray. Of course, I see the vestibular pin there. Here, I won't do anything on that. Look at the X-ray. We regain the volumes on the first premolar, regain the volumes on the second premolar. Now I can place an implant, a 10 millimeter implant here, and probably a 12 millimeter implant here. I'm not placing the wider implant, diameter implant here, but I'm quite happy. At least I can place 2 implants. And that's what I did, placing 2 implants, first premolar, second premolar, and this is the tissue I got. So I'm pretty happy. Again, as a scientist, is this 100% bone? Probably not. As a clinician, do I care? Probably not. Again, I do care that this is stable and will maintain my implants inside. Here is the implants, the 2 implants, then going to healing. This is the final healing of the soft tissue around the healing abutment. Soft tissue healing around the healing abutment. Here, see, even we regain the shape here of the soft tissue with the healing. And this is the final restoration. The occlusal view of the final restoration. This is a cantilever, as I said. And this is the buccal view of the final restoration. I'm quite happy. So even if in a heavy smoker with a big exposure, I can say this is a saver. This saved my procedure, definitely. A membrane like that, even if it got exposed, it didn't get resorbed like boom, and it didn't get contaminated. So at the beginning, I said, can we unify the needs and the evolution? Yes, we can, because with this membrane, the needs that are, having a membrane that if you get exposed won't get contaminated, and membrane that if you get exposed, it doesn't get resorbed. And this is definitely the evolution and the unifying of the needs of and the evolution, the permanent membrane, because as I said, if exposed, you won't get any resorption and you won't get contamination of the membrane. So nowadays, this is the membrane I use 100% of the time when I'm doing the socket preservation, if I'm doing the socket preservation. And in GBRs, where I run the risk of an early exposure of the membrane. Let's say I don't have enough soft tissue to close the case, the patient is not the best cleaner or is a kind of a smoker, so I use this membrane in those cases when I'm doing a GBR. And with this, I want to thank everybody for listening and for bear with me during these 55 minutes. So I leave 5 minutes for the question time. And now I will read the question and will try to answer. Thanks. Thank you, everybody. Okay. Barry, thanks for the question. Barry is asking, what hygiene procedures do you use to maintain the exposed membrane? As usual, on an exposed membrane, I use chlorhexidine gel applied with a small plier twice a day to maintain it clean. No major things. The other question by Dr. Barry Marshak is, have you placed implants simultaneously with this membrane? Not yet. I haven't done any simultaneous procedure yet. I'm still, on a kind of learning curve. I'm seeing the performance of the membrane before pushing it to an higher level. And this will be probably my next step. A guest asks, I don't see name, can I do the same with the resorbable membrane? I don't think you can reach the same with the resorbable membrane, because if it gets exposed, it gets resorbed much faster. And what I've seen since I've done many socket preservation with the resorbable membrane, you might lose the barrier effect too soon. So it's much better to use a non-resorbable membrane. Plus, as I said, this membrane won't get exposed. So if you're the type of clinician that likes to cover his grafting material with a socket preservation, this is the right membrane, I think. And the other option could be a connective tissue graft, but plus you need another surgical site from the palate of the patient. I always prefer to open the drawer and take something, a new tool, and use it instead of sacrifice the patient's palate and having another surgical site, so the patient will heal much slower. And I think when you have such a membrane, why not to use it? I think I answered the question to Dr. Matteo Piras. Dusan Brajovic is thanking for the presentation. Thanks for listening, basically. Oh, can you repeat the ice cream cone technique? This is a technique, you see the email on my last slide. If they can put up the last slide with my email, you can write me the email, I can send. Yeah, thanks. Here it is. Here you see my email. I don't have the pointer anyway, but you can see the email. Please write me a message and I will send you the articles referring to the ice cream cone technique. Basically, it's a technique presented by Elian and Tarnow back in 2007. And you cut a membrane, a resorbable membrane in a cone, in ice cream cone shape with ice cream scoops on it. Basically, you cut a triangle with a small circle on it. I have an entire presentation on this, but in an hour, this is way too much. If you write me an email, I will send you the article by Tarnow. When there is a chronic, Leonel Navarrete is asking when there is a chronic or there are chronic infections with large bone loss, which is the protocol. There is not a definitive protocol, but there are articles by the group of Dr. Barone, Dr. Covani, Professor Barone, that they published on inserting the implants on a chronic infection, and basically there is no problem as long as you remove all the infected tissue, all the granulation tissue. I'm not the I don't like to place the implant on an active infection, but on a chronic infection, usually, small granulomas, and I usually place the implants with no problem, and I haven't seen any major problems, to be honest with you. Francesco Oliveri is thanking for the excellent presentation. Thanks to Francesco for listening to me for an hour. Oh, thanks for writing my email anyway. I don't see any other questions here, so I think we can. Thanks everybody that liked the presentation. I'm really glad that was. I hope it will be useful and you can start using these, these tools tomorrow in your office or later on your patients today. I mean, I don't know which part of the world or the globe you're listening from. But if you're listening from the east side, you probably might have some time to use it in the next few hours. Do you use with this new membrane, Leonard Navarrete? I use periacryl with this new membrane. Usually I use non-resorbable suture barely. In these cases now I use resorbable suture, long-term resorbable suture that are very similar to nylon, but they're resorbable. I use Vicryl. Most of the time I use Vicryl, if in the posterior area. In the aesthetic areas, I rather use more performing, more modern sutures like they're monofilament, resorbable monofilament. They're not like the Vicryl. Okay. No more questions. Okay, since I don't see any other questions, I want to thank again everybody for being here, for listening to me for an hour, and I hope we can meet in person in the future. It's nice to talk in front of a screen, but it's much nicer to meet people, shake their hands, and hug them, and change ideas and opinions all the time, because this makes us growing and improving our clinical behavior. Thanks again, and I hope to see you in the near future.